Good morning, everyone. Welcome to my senior lecture. Not it. What?
Just click over it. Just click anywhere.
Any of that. I know it's only March, but it's been a really, really long year. And I just wanted to say how immensely proud I am of all of you. You've carried yourself with so much poise and elegance during this difficult pandemic. And there's no other group of people that I'd rather be doing this crazy pandemic thing with. So basically an applause to all of you because you've been amazing. Just starting, I think it's kind of amazing how a group of strangers suddenly becomes family. And so special thanks to my class for always being there for each other. And to this day, we're still doing crazy things all over the place. So when I was thinking what to do my senior lecture on, I wasn't sure what to talk about. This picture, I forced Sitter to take a selfie with me, and he was like, I don't take selfies. And I'm like, yes, you do. And there we are. So it was kind of difficult to figure out what I wanted to talk about. I don't really like talking about EBM as strongly as Dr. Senior. This is I do like my dog a lot. I like Koreans, in case you guys didn't know. And I'm also very interested in palliative care. So you guessed it, I will be talking about palliative care and death-related topics. I'm sorry, but not really. So let's start on with a case. You have an 88-year-old male, previous medical history of hypertension, AFib, CAD, diabetes, our typical case that we have in CCT, came in for respiratory failure, intubated in the field, status post PEA arrest, total of downtime of around 18 minutes, they estimate. On arrival, the patient goes into PEA arrest one more time, so you code him for about 14 more minutes and you achieve ROSC. Your junior is placing a cooling catheter to start TTM, and the patient is currently required max dose of norepinephrine drip. You're doing some short review, you don't see any advanced directive, no nexus of kin for you to discuss what's going on. In terms of his vitals, he's hypotensive, a little tachycardic, normothermic. His pH, he's acidotic. He has a troponin of 3 after having CPR, and his COVID status is still pending. You do an x-ray that shows that the ET tube is in place, single rib fracture to left rib 4, and you see bilateral pulmonary hazy opacities, which you don't know, it's multifocal pneumonia versus pulmonary contusions. Please correlate in proper clinical setting. You're waiting for a bed in the ICU, the red phone rings, and while you're talking to someone, it rings again. So it's that type of day. It's very crazy. You're done with dealing with 2 level 1s and you suddenly sit down. The nurse calls you to bedside and you're like, ugh, okay. And you see this on the monitor. The patient loses pulses, and you quickly grab your ultrasound and you don't see any organized cardiac motion. So what do? The nurse asks you, want to start CPR? I'm not sure. Is there really any benefit for us to try again on a patient that already coded twice with a PEA arrest? Do you want to soft code it? Is there any benefit in that? Or do we just call it? And so that brings us to the topic of my lecture, and is withholding medically inappropriate care and just letting go. I just want to discuss, when is it that we should stop? Do we even code people if there's no chance of medical recovery? Do we soft code and know that there's no change in outcome possibility? And what is the right answer regarding these difficult questions? So I'm sorry, I plan not to put you to sleep like Sophia and lecture as an intern, but the objectives of my lecture are to talk about CPR outcomes. CPR is a de facto treatment for cardiac arrest, ACEP's point of view, as well as AMA point of view, and what are my recommendations regarding this topic based on what I read. I'm sorry, Sophia. I asked you, you said yes. Just so disclaimers, I believe in medicine. I don't want you guys to think that I don't. I believe that CPR works when it is provided to a certain group of people that are going to benefit from it. I believe in resuscitating my patients and trying to give them the best outcome possible, but I also believe in peaceful death and no causing further harm. And this is one of the biggest reasons which I am going into palliative care, because I think dying is also kind of poetic and we should allow a body to just pass peacefully as well. So in terms of the goal of CPR is to restore normal circulation, organ perfusion, and reverse clinical death from a non-perfusing heart rhythm, basically. However, CPR actually works relatively infrequently. I think both the media, people, and us physicians have a very inflated idea of what CPR can accomplish. Oftentimes we overestimate the benefits of giving CPR and severely underestimate the consequences and harms of performing CPR. So let's just start a little bit of EBM for Sinner then. This is an epidemiologic study that was done from 1992 to 2005, multi-center. They basically just gathered data of in-hospital cardiopulmonary resuscitation survival rate in elderly population, meaning older than 65. They actually looked about almost 500,000 patients, and they realized that around 18.3% survived to discharge. So if we do the math in terms of the span of 13 years, that means about 78,000, 1,100 people that actually survived in 13 years from in-hospital cardiac arrest, more than 65 years. So does it work? Yes, about 20% of the time. And this was from 1992 to 2005. And then here, it was a cohort study that they did from 2008 and 2017. There's actually, evidence that actually from this year, 2008 to 2017 or so, the survivability from in-hospital cardiac arrest actually increased about 5%. We all know that shockable rhythms have better outcome than non-shockable rhythm, but basically the composite of this and this puts you on around 25% of survivability around the year of 2017. So that's a significant percentage, 25%. And then most studies basically oscillate under the same survivability, 15 to 25, depending on which hospital and level of care that the patient is having. However, survival to discharge is very different. So things that influence survival to discharge have to do with downtime, presenting rhythm, underlying medical conditions, their response to out-of-hospital CPR, and if the patient comes from a long-term care facility. Actually, certain groups and certain studies have shown that the rate of survival almost reaches 0% for people of long-term care facilities that had unwitnessed arrest. So that's 0% for long-term care patients that had unwitnessed arrest. Moreover, this study here about cardiopulmonary association not indicated if you have patients with advanced progressive illness, significantly metastatic cancer, liver disease, HIV infection not controlled, dementia, multi-organ failure, the rate of survival to discharge is actually less than 3%. That's also a very significant percentage of people that don't survive to discharge to live their lives how they were before coming to the hospital. And this, in fact, has to do a lot to do with frailty, which means that you have an impaired physical function, you have reduced physiological reserve, you depend on other people for your daily life activities, you start having recurrent hospitalizations. And please make note that none of this here actually state age. Frailty is something independent to age. Frailty has been more predictive of any outcomes than age. So basically, your frailty will increase your morbidity and mortality after in-hospital or out-of-hospital cardiac arrest. This study by Ibiote, actually, it was titled Frailty Status Predict Futility of CPR in Older Adults. They were trying to see if there was a frailty threshold in which CPR becomes futile. And they saw that people over frailty scale over 4 actually had very low chance of survival of in-hospital cardiac arrest. Just a disclaimer, this was a retrospective single hospital study though, so not a great study. But they did found a statistically significant relationship between frailty and not survivability and futility and higher fertility scales. Which brings us then, if people that are considered more frail, what then are the harms of us giving CPR to them? CPR is not a benign procedure like most procedures. It can cause physical discomfort, it can cause rib fractures, it can cause defibrillation burns, as we see in the picture, unnecessary procedures like chest tubes, central access, veins, poking and prodding a body. It can cause loss of dignity because I don't know if you've ever seen a code in CCT or a downstage bay. Person's basically naked there with a bunch of tubes coming from their body. It can also cause emotional harm to the family seeing the person like that. And in my opinion, is unkind if it's gonna prolong a poor quality of life. For the physician, it has harms as well, because for us, it's frustrating when we do CPR and it doesn't change the outcome, or when we do CPR and the patient does have a perfusing rhythm afterwards, but you know the neurological outcome, it's not gonna change anything. So either way, it can also cause harms to the physician. So brings to us the question, then why is CPR the de facto treatment for cardiac arrest? It is interesting to me that for you to put a central line, you need to get a consent. However, for you to do CPR, you assume that everyone wants CPR. Actually, to not do this procedure, you need to get a consent, which is the opposite of every other procedure. You consent for a central line, but you consent for not CPR, which is kind of interesting. Who determined that society wanted CPR? So this study here actually just basically asked 724 volunteers what did they think about CPR. Most of the respondents thought that about 50% of the time the patients after cardiac arrest and have CPR will survive and go back to living their normal lives, about 50%. So basically the double of the real value. And then they actually divided it on different scenarios. Most people prefer to code younger patients with less comorbidities, like you see here. And then most people actually, when they realize patient has all these comorbidities, home resident, decided to not go for aggressive treatment. So society actually does think what most physicians think. If you have more comorbidities and you go into the frailty scale, you're actually less likely to survive. Most people chose not to do CPR on these patients. Interestingly, they divided by education level, personal belief, economic status, and just education. And they found no difference into what people would do for an older frail person versus a young healthy person. Most people would code a young, healthy person and not really on an older, frail person. And women were more likely to refuse CPR than men, which I thought was interesting. So it brings us then to the concept of futility. Futility is something that has a high likelihood of failure, and it's very improbable that the patient will recover. You have a rare probability of achieving return of vital organ functioning and poor survival after a short period of time. And this can lead to a poor quality of life that just falls below the threshold of what we as physicians and as humans think is acceptable. And I think it's also more than just CPR and futility. It's withholding medical care that we know is inappropriate. And this we do every day. Like, A surgeon doesn't offer a surgery if they know the risks are far too much than the benefits of not doing so. Then why are we not doing the same with this procedure? CPR that clearly would be of no overall benefit and would meet no reasonable goal doesn't need to be offered. Do not offer CPR if the burdens entails far outweigh the benefits. Explain to the family why it would not be an appropriate decision. And like everything in medicine, it is a risk-benefit analysis. Evidence medicine that we practice every day is based heavily on current research findings by large randomized controlled trials. However, this is not something that we can randomize like that. Oh, you get CPR, you don't get CPR. So unfortunately, what we can use as a general guideline is our individual experience and the best current evidence and go from there. Like I said before, we do this every day in medicine. Every intervention, every medication we give has a side effect profile and a therapeutic range in which it will work or versus the risk that it'll cause some harm. We do it with TPA, we do it with CT scans, basically everything we decide to give in the emergency department. And I believe that CPR should be performed in patients that will benefit from it the same way. And then what is the American College of Physicians say? Emergency physicians caring for patients in cardiac arrest who have no realistic likelihood of survival should consider withholding or discontinuing resuscitative efforts in both pre-hospital and hospital settings. This one's very important. Physicians are under no ethical obligation to render interventions that they just have no realistic likelihood of benefit to the patient. Emergency physicians' judgments to withhold or withdraw requested interventions should be unbiased and should be based on available scientific evidence and societal and professional standards. So this is ASAP's point of view regarding futile emergency medical interventions. What AMA Code of Ethics states is when efforts to resuscitate a patient are judged by the treating physician to be futile, even if previously requested by the patient, CPR may be withheld. So we seeing the ideology of our major colleges by which we practice our medicine are saying that this is okay to determine futility us as physicians with the knowledge that we have. So what is our duty as physicians? If you really want to make the case for attempting aggressive, life-sustaining, rib-crunching CPR, then you should weigh all the risks and benefits of doing so. This can be reassessed during the code, as well as when circumstances change, you get new information regarding the patient's data and condition. But if you decide that there is no benefit of this intervention, then it's also our duty to understand that we have to let go. We need to understand the limits of both modern medicine and the human body, and that it's okay. It doesn't mean giving up. It's just normal, natural physiology occurring. And then what do we say to the slow code? Not today. Why? Because it is a symbolic gesture, is essentially a lie. You're wasting resources, even when you know it's not going to change anything. You're doing it just by how it looks and not really expecting it to work on the patient. So I think slow codes should not be done. You should stop the moral injury. Just do your job as a doctor. You did good and you prevented harm. The only caveat that I could find to this is that we as physicians, but mostly humans with feelings, we need to accept that the benefit of limiting therapy is gonna outweigh the maleficence of inappropriate limiting therapy. Are we absolutely certain? Unfortunately, in medicine, will never be. Less of what the medicine we practice, 1% actually has good evidence behind it. So as medicine, our daily affairs, we act on the basis of empirical evidence. We'll never be we'll never know if the benefits are more than the maleficence of inappropriate limiting, unfortunately. We're only human, and that is okay. In terms of our case resolution, the third round of CPR was deferred. Patient release subsequently expired. It was interesting, though, because the nurses actually got very angry at us and refused to do anything for the rest of the shift. They left the patient connected to the monitor, to the ventilator, and to all the drips because they're really angry that we didn't attempt CPR. However, I thought it was funny because I'm sure that most nurses are ALS trained and they could have started, but no, none of them even went into the room. I had to do everything for this patient and disconnect him from the monitor and take care of him, make sure that he was clean and his body was passing in a dignified manner. So what are my recommendations? It's finding a balance between helping the patient and not harming the patient. Consider what type of life the patient is gonna have after CPR. Consider giving CPR to those who you know will benefit. A treatment may be futile, but a patient is never futile. Please understand this. It's a treatment that is futile. The patient is not futile. You offer aggressive comfort care instead if you feel CPR is not going to change the outcome. And instead, consider just the scientific evidence of likelihood of benefits, the potential risk of the intervention, and the most importantly, the patient's pre-morbid state, which is going to let you know if the patient can actually survive CPR. So in conclusion, like I showed you at first, CPR does work about 25% of the time, more so if you have a shockable rhythm, but it shouldn't be the de facto treatment for cardiac arrest. When a treatment is considered to be ineffective by a physician, it should be contraindicated. And the decision to do CPR should be based on the chance of survival, but when you survive, how your life is gonna be as well. Human beings are mortal and the power of medicine is limited. So you have to appreciate the beauty beyond the sadness. You help the body pass peacefully and you preserve its dignity while upholding your oath as a physician. And so there's nothing wrong with doing this. And these are my references. You have any questions?
One question. What's your viewpoint on quote unquote slow code to allow family to come in during resuscitation if they wanted to, or to, I guess, allow family to arrive?
So I understand what you're saying. I just don't feel like wasting medical resources is going to change the outcome of the patient. And
it's not about outcome, definitely. Yeah. It's more about the families.
And I understand your point about helping the family. I'm just not sure that you seeing a body in that state actually helps you give closure.
I don't know either.
There's stories that say that is helpful with family for closure, and they appreciate it again, and it makes it a little easier to come to the finality of what's happened this year in its effect.
I'm just wondering if those studies only show the point of view of certain cultures, because I feel like as a Puerto Rican, that would be different in my culture.
I don't think that's ever looked at. I don't think anybody writes down what culture.
I was wondering if you came across anything about like the medical legal aspect, because I feel like that's often what is playing in people's heads when they're like, oh, I have to do this because I'm going to get sued, or like, did you come across that?
Yeah, I deleted that slide. I shouldn't have because I thought I was talking too much, but I wrote some comments. So reading about EMTALA, so EMTALA doesn't really dictate which interventions or procedures must be performed. You actually have to stabilize the patient. However, if the patient doesn't have a rhythm or a perfusing heart that you can stabilize, there's not really much that you can do as long as you're offering medical care. You're not treating them. You're just not giving them CPR. And those are two different things.
It's probably been about 5 years since I've looked into this. It was a topic I'm interested in, but there was a lot of things that showed that there's never been any medical, legal, or legal action taken against a physician who reasonably said that it was feasible care. We had a lecture from I forget who it was, I think he was an ethicist and also there. He said probably the best way to do it is to have two independent physicians state the same thing and write a note stating that. Obviously, it's not always easy or possible to do that, but that's probably, if you want to do that, standard. Two people say that.
Yeah, and I read about a case that did want to go to court, and basically they ruled in favor of the physician, saying that there was no negligent action, as they ruled by their medical standards that giving CPR was going to be futile regardless.
I have a question about nursing. Like, why were they so angry in that particular case?
Because apparently that's not how we do things. We always have to do CPR for patients that are pulseless. And they viewed it as us not trying to save the patient.
Yeah, and you don't know if there was some other personal beliefs or cultural beliefs going on too, right? And sometimes it's hard to separate. I don't know if that's the case, obviously, in that, but I wouldn't doubt if some of the people there, they felt that it should be their belief.
Right. But I thought it was really weird because they're also ALS trained. They could have started it if they were against what we thought was correct.
That was great. Is there anything that you came across that allowing the family to be in the code and then later them more acceptance after they see an effort and was futile of accepting that the code was then stopped?
Yeah, so like Dr. Silverberg said, there is data that shows that it does help the family come to terms with what's happening. I just feel like you can also let the family come in and explain why CPR would be more harmful. Like I said, most people, and I think this is mostly because of the media, believe that CPR is going to bring them back. But I think there has to be a more education of the general population as to the low survivability that this procedure actually entails.
I think you have to prepare the family.
Yes.
You know, I think that's the most important thing, is to say, listen, he's very, very sick. And I always use the term make them comfortable. And I've never had any pushback when I said to the family, I'm going to make them comfortable. And I'm going to do everything that is medically indicated. And then I've never had an issue with CPR or not CPR, because CPRs, I always think of CPRs like you said, like any other medical therapy. You know, it's like giving Discharge. There's certain indications for it, there are certain indications not for it. You know, CPR and ACLS was built for cardiac arrhythmias. That's where it works. It doesn't work in people who have pneumonias who stop breathing, you know, who have cardiac arrest. It's just septic shock. It doesn't work. There's some very good studies that show it was built for one specific medical indication. And for that medical indication, I'm sure if you look back at the 25% survival, it's almost all cardiac arrhythmias. Yes. It's not septic shock. It's not people with terminal cancer. It doesn't work.
It's the data. It's mostly driven up to a high percentage just because of the shockable rhythm arrest. Right. Otherwise, the other one's pretty low. The non-shockable rhythm ones.
Yeah, and that's the cardiac rhythm. It's not what other underlying conditions you have. But I think if you explain to the family, listen, what's going to happen in the next few hours or a few days, this heart's going to stop, and there's nothing we can do. But there's no therapy that reverses what that. The patients are very accepting of that.
Mm-hmm. Some years ago, now there was a study I forget where they looked at 3 factors: GEA arrest out of hospital, CPR initiated either not by a medical professional or just didn't have CPR initiated by someone who knows BLS, and no ROS after your first dose of EPI. And so if you had that, a GEA arrest where CPR wasn't started in the field by a trained professional and you didn't have ROS after your first dose of EPI, you had a 0% survivability to discharge. Which makes sense, but each of those independently we know are 4 predictors in separate studies. And I think that's a lot of what our patients are, right? When you have patients come in with DA arrest, it's very frequently they have DA arrest, nobody at the scene is trained on how to give appropriate CPR, and you give your first dose of epinephrine and you don't get ROS on your first dose of that. So I really utilize that. And we all know that independently, like I said, that those have 4 predictors for survivability. And I think when we know that early on, that within the first 5 minutes of the patient arriving, I already have a thought in my mind that, okay, a lot of the data shows that this patient's not going to survive. It's always tough when patients come to the emergency department and they didn't have a prolonged course for families to accept it. I think no matter what we do, it's very hard to prep the family because the patient's arriving and they're going to be dead very soon. But at least I know within my first month, I have to get family a lot quicker than the amount of resources I need to do on this patient. Because that's going to be the more time I spend prepping the family is going to probably be the better result of this than spending 30 to 45 minutes to an hour on resuscitation.
Actually, an important point. It's one of the things I learned from Dr. Lucchese that when you treat these patients, you may see 50 or 100, even more patients die during your career, and you may not remember them all. But that family will remember how you as the doctor were with them every single time. It's really an important point.
Okay. Just lastly, I wanted to give special thanks to my favorite beings, the Korean, Carolina, and my dog. And then special thanks to my family back at home, which I miss dearly, and my family here, all my class, and everyone in residency. Thank you.